So, good evening, everybody. Welcome to the fifth ski webinar. And this is a very interesting webinar, which is going to be conducted by Dr. Ashok Rajgopal. And he has put up some very interesting cases on complex TKRs and revision TKRs. But before we go on to the cases, I would request Dr. Sachin Tapaswi to give a talk, and he's going to speak to us on implants in complex TKR and revision TKRs. How do you choose? How do you decide the level of constraint? So this would be a talk for approximately 15 minutes, and then we go to the cases which will be presented by Dr. Ashok Rajgopal. We have a very interesting faculty. We have Dr. Vijay Bose, we have Adarsh Reddy, we have Mukesh Ladda, Jacob Varghese, Vikas Kapoor, and Sharan Patil. And it's Sharan's birthday, so happy birthday, Sharan. And on that note, over to Sachin Tapaswi.
Yes, thank you, Parag, and Sharan, a very happy birthday. So we'll sing you a song at the end of today's webinar, and we'll expect a virtual
Don't
toast
embarrass
as
me.
well.
Thank you.
Right. So, as an introduction to today's webinar, which is essentially going to be dealing with issues of complex primary and revision situations, especially related to instability and how do you reconstruct bone and how do you compensate or reconstruct ligaments, we thought it apt to just have a small introductory presentation to lead up to the same. So one of the important aspects that we always use in all our sort of surgeries which are away from the standard mild to moderate deformity is the role of constraint. And stability is absolutely essential if we want to have a long-term functioning total knee replacement, which is completely important. Knee instability is a major cause of failure. So if you look at the current data that we have, knee instability accounts for the second most common reason for revision in today's scenario. So recent papers would quote that probably instability has gone a notch higher than infection. Of course, this is the data that has been quoted by all the Western literature. I think in our country, probably infection is still the major cause of revision, but although instability is not lagging far behind. So what are the different tricks and tips that we use to encounter instability? Of course, reconstruction of bone is an important aspect. And the other major aspect of it is to try and compensate for any form of ligament laxity there would be. The thing that we use quite often is constraint. And what do we mean by constraint? Constraint is essentially the level of mechanical support that we use to provide a stable functional knee. So this constraint could be very low, as in a semi-constrained knee like a CR knee, or it could be very high like a rotating hinge. And of course, we have a huge spectrum of constraint that lies from the mobile bearing sort of partial knee, which is a non-constrained implant, to a rotating hinge. And that's what we'll try and understand in the next couple of minutes. Why do we require constraint? As I just mentioned, I think key vital structures are not sort of doing their proper role. And I think we need to do something more. And this is where these soft tissue laxity will be then compensated by certain mechanical implant characteristics in the implant, which bring about this constraint. These, these essentially will accommodate the loss of support, which is there in the current scenario that you're dealing with. When should we do it? I think there are three main indications. When you're not able to balance your flexion and extension gap, and it is usually the flexion gap which is the problem rather than the extension gap. The second indication is mid-flexion instability, which I would not say is a new concept, but is a definitely well-recognized concept. And I think with increasing number of knee replacements, there's a higher chance that we will start identifying more and more patients who are not happy because they have mid-flexion instability. And lastly, we're going to be looking at the cases of global instability, especially following trauma or infections, or if you've done a tumor resection, which seriously compromise the insertion points of your collateral ligaments. How do you achieve constraint? I think the most common way that we do it is that we increase the central post in the cam and post mechanism, and we make it higher and wider, and thereby we achieve constraint with the help of a non-linked high central post. When we require more constraint, we just make this high central post linked. We link it with the femoral component, and what we use is a linked hinge rotating platform. It is extremely unusual and it is not at all common where we use just a linked hinge without a rotating platform because of the unacceptable sort of rate of loosening. So essentially, our main focus is going to be on the constrained non-hinged implant. So essentially what this is it's a tall post in the middle of your plastic insert, which mates with the cam of your femoral component. It's a large central post. It substitutes predominantly for the LCL, and if you have minor to moderate degrees of MCL laxity, it may help substitute for the same as well. This is very important to understand that a PS knee is not a constrained knee. A PS knee acts as a semi-constrained knee because the height of the post is not large enough to compensate for a defunct or non-functioning LCL or a compromised MCL. So the main indication is MCL attenuation. I purposefully put a star on MCL deficiency. If the MCL is completely deficient, you cannot use this non-hinged constrained implant. LCL attenuation or LCL deficiency is the more common indication where we use it. And when we are left with a flexion gap laxity, I think there is a role for this particular insert to be used. So let's look at this 73-year-old lady with a normal BMI. She's got a deformity which is which is not passively correctable. You can see on the x-rays that this is somewhat of a type 3 valgus, and she required a complete release of all her soft tissues on the lateral side. And we can see here that we've sort of elevated all the tissues from the lateral side, released it right down, and we were able to achieve correction. But of course, we had to protect the lateral side by the attenuated lateral side, which we had to release completely with the help of a constrained prosthesis. And that's her 3-year post-op follow-up. So a constrained prosthesis, what is important, which does not have a hinge, is that it will provide rotational constraint. And what you need to understand is what is called as a cam hop height. And this hop height is going to determine what sort of jump height your prosthesis has got, which makes it completely stable during the arc of flexion extension. Some systems, or most of the systems, will allow a continuum of constraint, like what I've demonstrated here. The bearing increases from a standard CR to a PS to a PS plus to a SSK PS, which has further increased not just in height but in width as well, to a completely sort of varus valgus constraint, where it completely fills up the femoral cam, thereby achieving a good stability in a stable reconstruction. So the predominant indications for using a varus valgus constraint in the primary TKR would be a valgus osteoarthritis with an incompetent MCL, a severe flexion deformity where you're not able to balance the flexion extension gaps, bone defects which are especially uncontained, which cause compromise of your collaterals. If you have an extra-articular deformity in certain situations, you may require to use them. If you have varus valgus laxity, which is more than 5 millimeters throughout the range of motion, I think that again is an important indication. And these are some uncommon indications where you have rheumatoid arthritis, especially in valgus, where you've got neuropathic arthropathy, poliomyelitis, or an uncontrollable flexion extension gap balance. These will be uncommon indications for the same. Midflexion instability, which is not recognized at the time of initial surgery and which presents with pain, laxity, and instability later on, again will require revision to the use of a VVC or a varus valgus constrained implant. A simple PS implant will not be sufficient because the post in a simple PS implant still has rotational freedom. Still, in flexion, it is going to be a shallow box. The articular congruity is not going to be as much as what it will be with a VVC type of an implant. And usually these patients will have a deficient anterior third of the MCL, and they require sort of a revision to a more constrained varus valgus support. And this requires, in my opinion, a non-hinged constrained implant like the VVC. Another example here, this is a revision scenario. This is the second stage which has been done. And with the help of non-constrained implants, one can see that this is not a knee that is stable throughout the range of motion. The the lateral sided structures are definitely lax in this case, and this requires the presence of again revision with the help of a constrained implant. And this was the final follow-up at the end of 5 years with good flexion and extension. We then come to the next degree of constraint, which is the hinge rotating platform. I don't think in today's world there is much role of using a non-rotating hinge. We have to use a rotating hinge so that we are able to give our patients better function, better stability, and less loosening. The major indications, I think the most common indication is a hyperextension type of instability, which may be neuropathic. And the other indications may be when you have complete loss of the MCL, there is no choice, but we have to go to a rotating hinge. If you have global instability, either because of soft tissue destruction or because of segmental bone loss, that again becomes an important indication to use a rotating hinge. Here is one such example of a patient who had a primary knee done in poliomyelitis. Unfortunately, the surgeon did not recognize the amount of hyperextension and his poor soft tissues. This led to the whole knee feeling completely globally unstable and required revision to a rotating hinge type of a prosthesis. So again, to sort of reiterate, the indications to use a rotating hinge in the primary scenario will be if you have bone loss, if you have severe bone deformity, fractures, neuropathic joints such as poliomyelitis, and sort of advanced recurvatum. How are the long-term results of these rotating hinge? I think if you look at the cumulative incidence of aseptic loosening and all failures, they do pretty well, around 5% aseptic loosening at 10 years and almost about 20% loosening at 10 years. Mind you, only 18% were done for a primary situation then. Another good paper that came out of the Rush group, in which they looked at 80 rotating hinges, and it formed the survivorship was almost about 71% at the end of 5 years. So you have to choose your implants with care. I mean, I don't think you should be unnecessarily doing advanced constraint. You have to choose and pick and evaluate your amount of instability and look at it. These are some comparative data of papers that have been published on the use of rotating hinges, both in the revision and the primary scenario. And what we see here is that they have decent survival. Of course, you have to look at your indications properly, and that will help you achieve a good functional outcome. So I think to conclude, constraint is an important aspect in our armamentarium when we're dealing with total joint replacements. It's important to understand that you should use the least amount of constraint as what is required for that particular case. If you use a higher constraint than what is required, it could be a bit of overkill, because the higher you go with constraint, your function will certainly drop, your mobility or the satisfaction rates are going to drop slightly. So that's why you have to use the correct amount of constraint as you feel comfortable. It's important to understand that if you use a high PS post like a VVC type of an implant, you're going to fulfill majority of solutions that you encounter both in complex primary as well as revision surgeries. And if you have to salvage a bad knee which has come very unstable, or if you have a multiply operated knee, then I think rotating hinge will be the go-to for in your surgical treatment. So this, friends, was a brief overview which is going to lead up to the interesting cases that we have here to come. And I turn it over to Dr. Parag Sencheti and Dr. Ashok Rajgopal for the subsequent interesting cases on which all of us will have a good discussion. Thank you very much.
Thanks, Sachin. That was a nice talk to lay the platform for the cases. While I just put up the presentation for Dr. Ashok Rajgopal, sir, there's just one question on mid-flexion instability.
Yes.
The question is how to examine mid-flexion instability intraoperatively and in the clinic once the patient comes for a follow-up. So while you answer that, I'll just set up the talk.
Okay, so each one will have his own trick as to how he looks for mid-flexion instability. Essentially, the way I do it intraoperatively is that if I'm doing a PS knee, I'll put a simple CR insert, or if I'm doing a CR knee, I'll put a flat insert. I won't put in a lipped insert, and then I will take the knee through a range of motion. And much like how you do a pivot shift test when we're examining ACL, I will do a similar kind of test and check for instability in the mid ranges, and that gives me a fair clue whether my knee is going to be unstable in the mid ranges. Also, if there is enough laxity, especially in the AP plane, when you're closer towards 90 degree of flexion, that will suspect me that the patient has got mid flexion instability. Post-operatively, I think one of the major telltale signs that the patient will give you is that they find it very uncomfortable coming downstairs, especially, and they keep on having these painless effusions or effusions which keep on bothering them whenever they have done extra activity. When you examine these patients closely, they will have an effusion, they have diffuse tenderness, and when you examine them in a sort of, when you sort of try and move the knees side to side, you may feel the slight juggle, which is then what would suspect you to have a mid-flexion instability. So Parag, that's how I usually evaluate my
perfect.
patients intra and post-op. So if anyone on the panel has got a few other tricks that they would like to share, we'll be more than happy to hear from them as to how they
Yeah.
evaluate their mid-flexion instability.
Anybody wants to just give a quick answer of their assessment before we go on to the cases?
So,
Rajgopal.
Parag, one of the things that I find very useful is if you hang the leg over the side of your examining couch,
Yeah.
and put your finger, put your forearm under the lower end of the thigh, just above the knee, and try and distract the knee joint. A patient with a subtle instability will complain of a distinct feeling of discomfort. And these patients are often known to say that that's the kind of feeling that they get when they are trying to come downstairs. You know, the point that Sachin just made, because subtle instabilities are present far more commonly than we actually diagnose and give them credit for. A lot of these patients who are unhappy, I believe, are flexion unstable.
Okay, perfect. So
So do you mind if I just mention how we do it intraoperatively at Sunshine?
Sure, Adarsh.
Pretty simple procedure. We just take the ball of the foot in the palm of the hand after we put our inserts, and at 30 degrees, 60 degrees, and 90 degrees, we just rotate the foot, and then we just see if it's popping out or not. So that's just a quick way to see in our 10 commandments. That's one of the steps that we check.
But popping out takes a lot of force, Others. So that may not be really directly indicative of a mid flexion instability.
Parag,
Definitely,
I
it
would
will tell you that
intervene
something
once.
is wrong, and that will definitely make you think, and that is the time you can actually correct that mistake.
Yeah, Parag, can I
Yes.
just add to what
Yes.
he has said?
Yes.
Hello, can you hear me,
Yeah, please,
Parag?
Vikas,
Yeah.
you can.
So with the ball of the foot, the heel in hand, from extension after surgery with the knee not closed, we just start bending the knee up to the full range of motion without putting our hand elsewhere, just with one force. At certain point, if the knee feels like giving way, like a mild slight subluxation at some point of time during the range of motion, that is the time I realized there is definitely some kind of mid flexion issue there. Most of the time the knees go through the range of motion with full pressure very easily. They go range of motion completely, and then I know that probably this last way.
Correct. So that's what Adarsh was saying exactly.
Pivot
Yes.
shift, yeah. So you're trying to do a pivot shift. I think different ways of doing it, but basically what you're trying to do is something like a pivot shift. But Parag, can I make a point on Sachin's presentation, the last slide?
Sure. Sure.
The conclusion, Sachin, of course, absolutely right. But when you go to a hinge, of course, you don't want to use a hinge unnecessarily. But for especially beginner surgeons who are going into revision surgery, this advice of use as little constraint as possible is not a valid one, because the instability in a revision is complex, difficult to make out. So the advice, especially for junior surgeons, would be use a CCK, TC3, and don't use PS unless you are a very experienced revision surgeon. Would that be fair, Ashok?
Yeah, I think so. That is what I said, that you should not overkill with restraint. Use the correct amount of restraint and maximum number of your complex primary and revisions. You can get away by doing a VVC or that is a varus valgus constraint, either LCCK, TC3, or whatever system you have in your.
No, Sachin. What the point I'm saying is a lot of us use PS in a revision scenario. Yeah, so you can do a PS if you're comfortable, but the general advice is for the beginners not to do that.
I think yeah. So those points will be
rather than undo the constraint.
Yeah, Vijay, those points will be well covered by Dr. Ashok Rajgopal in his cases. I have seen some of them. So that should be good. So over to Dr. Ashok Rajgopal for his case presentation. This is his first case. So over to you, sir.
Right. Thanks, Parag. That was an excellent presentation, Sachin. I think the preamble was absolutely perfect with some of the questions leading up to this presentation. So depending on how much time we have,
We have about 45 minutes to an hour starting now.
Okay, so we have 4 primaries and 3 revisions. So let's just try and quickly cover. So this is a patient who is a 69-year-old female. She's hypertensive, hypothyroid. She had a primary TKR to the cruciate retaining type of procedure done in 2007. She did really very well. She had no real complaints until about a year ago when I first saw her. And at that point in time, she had a feeling of giving way. She was mildly unstable, a low demand patient, rather obese. So we counseled her for, being kept under follow-up. And if we can get the next slide up, Parag. Yeah. So if you can, maybe somebody from the panel can just comment quickly on the on these X-rays. So maybe Vikas, do you want to take that?
Yes, sir. This looks like lateral laxity to me on X-rays, and probably post-fall.
Yeah.
But yeah, so on valgus strain, as you said, that it's less than 10 millimeter medial opening, more than. But on the X-ray, primarily it looks like lateral side is opening up, so patient has probably torn the lateral collateral or posterolateral corner or something.
Anything else that you want to comment? Anybody wants to comment on these on the X-ray?
There is posterior sag.
Absolutely right. Yeah.
Very
So
obvious,
this was a crucial. This was a CR knee done 2007. Patient was absolutely asymptomatic, I'm told. I did not do this primary surgery, but their family friends have been seeing them for many, many years. And absolutely right. You see a posterior sag sign. She is unstable, and there's about 10 millimeters of posterior translation. So any comments? Let's start with you, Sachin, since you made such a wonderful presentation on constraint. How would you tackle this? What would be your first choice of very quickly, 1, 2, 3? What would you like to do?
So what we are trying to tackle here is posterior instability as well as lateral opening. The lateral opening is not gross, and I think conversion of this particular prosthesis from a CR to a PS probably would do the trick. I would have an LCCK as a backup, but my primary plan will be to convert it to a straightforward PS knee.
Excellent. Any other diversions? Any other contra opinions?
I would certainly I would go for a TC3. So I wouldn't do a PS on this chronic situations. Yeah. So in chronic situations, there's probably she ruptured her cruciate, and that's what caused it. But in a chronic situation, you have secondary laxity. You have other structures that become lax. So I would go to a TC3 straight off.
Okay. Anyone else? Anyone would like to consider a hinge or any such thing?
I don't think so. A hinge would be necessary because once we go in, at the most LCCK as a backup should be good enough. But as I agree with Sachin's plan as the first line of treatment, but on table, if you're having some surprises, it's good to have a backup of.
Absolutely. So, these were the questions that were in our mind. We have wanted to check out the intraoperative stability, EUA. Our exposure was a standard. We have never diverged from anteromedial. At worst or best, we do a rectus snip and varying degrees of rectus snip. And these were the things that were in our mind as to what we needed to do for this. So we did exactly what you mentioned, Sachin. She ended up with a PS. We increased the height. We changed from a CR to a PS. The tibia was really very, very well fixed. We used a 17 millimeter polyethylene, got excellent stability. This lady is now 2 years out, doing everything that she wants to. One of the things that I want to sort of mention on this lateral view is when you're doing this unconstrained revisions, one of the key components of the revision procedure is to pick out the right size of your femoral component, because that also takes care of your flexion gap. So you basically upsize your femoral component. The second point that I like to make here is, if you notice, we have been able to adequately restore the posterior condylar offset. For me, the posterior condylar offset is a critical issue, both in terms of giving a patient an acceptable knee. A forgotten joint score has a great merit in restoring the posterior condylar offset, and this also gives a very good range of flexion. So this lady is 2 years out, has about 120 degrees of stable flexion, is able to climb up and down stairs. As I said, she's not a particularly active person, but she is able to do everything that she needs to, and is really quite happy with her outcome. I saw her about 6 weeks ago, just before this COVID stuff happened, and she's really very, very happy with her outcome. Right. So,
may I ask one question?
yeah, sure.
Sir, what are the tips and tricks in primary as well as revision to restore the posterior condylar offset?
Okay, so that's a great question. Now, you know, the issue really is, in a way, somewhat historical, because some of the earlier designs we had limited sizes of the femoral component. So when you were between two sizes and you were a CR surgeon, you tended basically to upsize the femur, and if you were a PS surgeon, you tended to downsize the femur because of the cam and post. With the advent of your newer implants, and there are various options in the market. The two things that I would like to sort of mention is, when you are sizing your femoral component, size it to the lateralmost aspect of the ridge on the anterolateral surface of the femur. By doing that, you get a slightly upsized femur, and you will be able to adequately get the right size, and that will give you the appropriate posterior condylar offset, because posterior condylar offset also has a bearing on what we call the dwell point, which is really the point that dictates the fulcrum on the medial side of the medial articular surface, around which that has an excursion of between 1 to 3 millimeters, and it's around this that if you have a snug compact medial ball, as it were, if you look at the little wheel concept, you'll be able to reconstruct the posterior condylar offset.
Okay.
You revise the CR with the PS without using revision component, is it? Is that correct?
Sorry, Vijay.
You took the CR off, and
I changed only the femoral component of. I retained the tibia. Tibia is very, very well fixed, and we changed the femoral component from a CR one size up to a PS. Got an excellent stability. We went from a 14 to a 17 articular surface, and the patient has really done quite.
Okay. So how do you upsize without posterior augments?
Sorry?
So how do you upsize the femur without posterior augments?
You don't. You just use a next size up. You use one size bigger femur. You don't need to use an augment. I mean, you can obviously use an augment. The problem with an augment really is, in this particular case, it was not needed. And my own bias really is, I would use augments really with a stemmed femoral implant, because the torque on the interface between your augment and the bone is really quite considerable. So if I am not using a stem augment on the femoral side, I would tend to use a upsize, one size up femur, rather than using posterior augments. They do quite well.
Sir, there is one point which I wanted to ask you. Don't you think 14 mm of primary CR insert poly was an indication which you would have got intra-op that this was probably going to fail in 10 years anyway, with such a thick insert in CR, which is rarely done by us?
Because, as I said, this is not one of my primaries. This was done, actually, believe it or not, this was done overseas. And in 10 years, this patient was absolutely delighted with her results. She had absolutely no complaints. She, interestingly enough, comes from your part of the world. She's a Malwari lady, and she's been attending all the Durga Puja and doing all those dances and stuff. So she's really been quite happy with her outcome. And at the end of the day, I mean, we can talk about the height and so on. And I take your point. I mean, today we are more aware of the fact that you want to use the minimum size of insert. But I think there is sufficient data now in literature to say that 12 to 14 millimeters polys actually do quite well.
Okay, so I used to think that PCL would get more compromised with larger poly. We tend to cut more.
I think the reason people used larger polys was because they had resected more bone. There was a lack of understanding. And if you also notice the other point in this, very subtle, if you look at the tibial cut, it is in varus. And when I actually spoke to the patient and her operative notes meticulously kept by this lovely Bengali lady, the surgeon had attempted some sort of a kinematic alignment in this knee. So that would explain that.
Okay. So Sachin, you had a quick comment?
Yeah, no, I have a question. I think on the same point which Mukesh had asked, is that how do you restore posterior condylar offset? So my question to the panel is that in a primary situation, what would help you achieve a better restoration of the posterior condylar offset, an anterior referencing or a posterior referencing?
Okay, let me answer that. This is a question very, very close to my heart, Sachin. I very, very strongly believe, and it's almost a religion with me, that I would always only do an anterior referencing system. I would not do a posterior referencing system.
Okay.
Yes.
What would be the reason for that? What would be the thought process behind that particular referencing? Do you feel that it restores the posterior condylar offset better?
It does, and for me, the most important aspect of the posterior referencing system is certainly in our part of the world where you have severe deformities with varus and valgus. If you have a severe varus deformity and there is a tibial bone loss on the medial tibial condyle, there is a compensatory overgrowth of the medial femoral condyle. So if you use posterior instrumentation, you will turn that femoral component of yours into internal rotation, and you're exactly with that in a valgus knee which has a defect that is adapting to the defect in the lateral tibial condyle. So you would externally rotate your femoral component in a valgus knee and internally rotate it in a varus knee.
Yes.
Answering Sachin's question, I think posterior referencing would restore offset better.
That is what I thought. Yeah.
Yeah.
So I think there's been good discussion on this case. Should we go to the next case or any quick concluding remarks for case one?
So the only point I'd like to make here is that you need to do horses for courses. See what the patient needs. We don't necessarily need to revise both components. In fact, there is a very elegant paper that's came out in 2010 Journal of Arthroplasty. Single component revisions in the appropriate situations do just as well as full component, and there are very clear indications for both.
Okay. Okay. So let's go to the second case, which is on the valgus knee.
Right. So this is a patient who is a 76-year-old diabetic, obese female patient. So as you can see that there is a fairly severe valgus deformity in this lady. Very quick, maybe Sharon, seeing that it's your birthday, we'd like to give you a nice birthday present.
First thing is to look at
walk us through your thought process with this knee.
First thing is I would like to see if it is a correctable deformity. A stress view might help me in that.
This is a fixed valgus deformity.
Right.
She's 76 degrees. and she
Yeah.
has a fixed deformity. Her hips are
Yeah.
fine, her spine is fine, her contralateral knee is all right. This is an isolated unilateral valgus fixed
Yeah.
component.
Yeah. So it's obviously a situation where we might need extensive lateral release. I would still go by the anteromedial approach, do as much of releases as possible. If I find that I have to release beyond a point where there is lateral instability, I would go in for a semi-constrained knee, and that should be able to align and give me stability as well.
So can you, for the panel and for people listening in, describe your lateral release? When you say extensive lateral release, what does that entail? What do you do? What do you release? Inside out, outside in, pie crusting, lateral particular osteotomy. What do you do?
Yeah, I am not very fond of doing the lateral epicondylar osteotomy. I have not done many, and I would just stretch it out, use a laminar spreader, and keep releasing. And you go to the iliotibial band and all the structures which are tight. And at the end of it, the last one I would like to sorry. The last one would be the pie crusting of the lateral collateral ligament. So with that, I would check my stability on the lateral side. If I'm not happy, as I said, I would go through for a TC3 like situation.
Right. Anyone of the panel want to describe anything different that they do?
Well, my
it will be inside out for me.
I would do the same. If the valgus in extension, I would release the IT band completely. But if the valgus deformity is still present and I still haven't corrected the FFD, then I would do an epicondylar osteotomy. But I have only an isolated valgus, I will do a pie crusting.
Right. So yeah, there are very many different ways to address this problem. Some years back, we actually described our technique in the Journal of Arthroplasty and Journal of Orthopaedic Surgery. And more recently, in 2019, we published our experience in the seminars in arthroplasty, and I presented this at the CCJR. A couple of really sort of interesting points which we learned along the way. I thought I'd share this with you. The biggest challenge with valgus knees that we have found in all the years that we've been doing these knees is to understand at what point of time your lateral release is adequate and sufficient. Because one of the challenges that happens is when you over-release it, you get into the situation of a posterolateral instability. That's almost an impossible instability to correct with any kind of conventional implants, and you almost inevitably have to fall in line with the constrained type of an option. So by hit and trial, we actually came out with this, and we published this and described this. If you take your knee in extension after you've done your releases, and you're able to rotate your tibial tubercle past the sagittal plane, that means you can internally rotate it beyond the center of the trochlear groove. That is an adequate step in release. When we start doing your releases, you keep releasing it and keep doing this in extension. Once you're able to do that in extension, you flex this to about 75 degrees of flexion and do the same thing, and then you try that at 90. So if you're able to internally rotate the tibia at 75, 90 and full extension, just short of full extension, that is indicative of the fact that you've done an adequate lateral or a posterolateral release. And at that point of time, you can do your cuts and you can decide on whatever form of constraint or choice of implant option that you may need to use. So this is just a anecdotal thing that we have found extremely useful. We use this in every single fixed valgus knee, and it has stood us in good stead. And we've been extremely sort of gratified by this experience. So we can go to the next slide, Parag, where we can just see what in this patient, one of the challenges was we had a incompetent MCL, and in spite of our valgus release, we released pretty much everything, including the posterolateral corner, the pie crusted, the iliotibial band. We actually had to also take down the popliteus tendon here. And we treated this using a LCCK or TC3, one of those constrained type of an options. And this patient did quite well. Any comments?
Parag, can you show us the post-op?
Yeah, Jacob, you want to make any comments? This is the post-op X-ray. Jacob?
My only issue is that I'll definitely want to feel the medial side endpoint before I start to know whether I need to do anything more. So more than how much I corrected, I want to see what the endpoint is. I always release the IT band from the tibia every case when this valgus is an extension. So I know a lot of people don't do it. I release it from the tibial, from the Gerdy's tubercle, and then of course do the femoral rotation, try not to internal rotate. Do my trials before I do my posterolateral pie crusting. So that's the way I would go for it. But I need to get an endpoint pre-op or when I start on the medial side before I start.
Okay, anybody else before we go to the next case? Okay, so let's go to the case 3. This is on the extra-articular deformity.
Right. So this is a very interesting case. 74-year-old gentleman, diabetic, hypertensive, almost 17, 18 years back. He had a road traffic accident and had a bilateral lower end femur fracture that was treated conservatively. So this is his preoperative X-ray. Is now in severe pain, and anyone like to take? Let's talk about both the right and one to your left is the left, one to your right is the left knee, the one to your left is the right knee. So as you're like to take. First of all, would you use conventional instruments? Would you use navigation? Would you use robotics? Would you use eyeballing? What would you do?
Navigation.
Okay, anyone else?
I want to get a limb alignment X-ray to see what's happening.
Long alignment film.
Okay. All right. Can we go to the next? It also gives the post-operative X-ray, but your answer. We can go to the next slide, Parag, please. Okay.
Yes.
So this is. Does that answer anything? So the point that I'm trying to make over here is, so what defines your cuts in these knees? Who would like to take that question? How do you decide on your femoral valgus? How do you make your femoral osteotomy, your distal cut? Tibia is really it's untouched, but on the femoral side, somebody can walk me through the right side and then maybe on the left side. Vijay, you want to take that?
The principles doesn't change. You want your cut to be, distal cut to be perpendicular to the mechanical axis, the hip knee ankle axis. Whether it's valgus or varus, it's all the same. So I would put about 4 degree for valgus and 5 degree for varus using navigation.
Okay, you would navigate this. Any thoughts in your mind on when you would do a correction of this extra-articular deformity? Do you have any thresholds? In this case, would you have done anything differently?
Not really. So the long axis of the anatomical axis is, if you extend the anatomical axis and comes within the joint, it's quite okay for an intraarticular correction. So
Right.
I'd be happy to do an intraarticular correction in this particular case.
Right. So yeah, that's absolutely correct. I mean, you can do this with navigation, robotics. You can do it eyeballing your way through. A couple of points. There's an excellent article by Wang, and he's pretty much talked about the same thing that Vijay spoke about. If you cut at the mechanical axis, And if that cuts within the collateral ligament attachment, you can correct that as an intra-articular procedure. And if it cuts beyond the attachment of the collateral, then you need to correct the extra-articular deformity. And the closer the deformity is to the joint, the greater the chances that you may need to do a correction. Can we go to the next slide, Parag? I just want to, it's an interesting.
Yeah. Yeah, this is the one.
If you can just go.
Yeah.
Yes.
This...
So the point here that I would like to make is, if you look at the left side X-ray, it actually looks really very, very well aligned. And if you go back to the previous Parag, please. And this has been taken in neutral rotation. So when you have extra-articular deformities, always make sure that you get your knees in your radiology or radiographer takes the X-rays in neutral alignment. Because if you see the previous X-rays, it actually gives the feeling that it is undercorrected and the limb is still inverse. The actual reason for that was the fact that this patient had was X-rayed in external rotation, and it gives a bit of a dilemma as to whether the adequate correction has been achieved. So in this patient, we actually managed to get a reasonably good correction. Again, fairly elderly person, limited expectations, and has done quite well. Right. So can we move? Any comments from any?
Any questions?
We haven't had in a post-traumatic situation. The lateral X-ray would be helpful, and sometimes I do CT scans to see the anatomy of the distal femur is all right or not.
Yeah,
that's one thing which will be of some help.
Yeah, I take your point. The only reason we did not put that up was because it was pretty uneventful. There was no the angulation was in the plane of the anterolateral curvature, so which is the reason why I did not put this up.
And just the other thing is and to take the judgment call on if we are not using navigation or robotics, any of that, and doing conventionally, to get the rotation of the femoral side right, I would use the tibial cut surface, the Renauer block technique, to get the rotational alignment right of the femoral side, because the transepicondylar axis here could be haywire.
Right. Yeah. That's a great. Sharon.
Ashok, I presume you didn't use navigation. You use navigation for this?
No. Did you use navigation?
I never use navigation.
Yeah. So you put intramedullary rod in the femur. So how did you get it right?
So it is easy to you drill a hole, and if it is a varus deformity, you take it laterally, and under image intensifier, you can actually put a cranial reamer right up the medullary canal, and then you just proceed and do it the conventional way. That's what we do. Yeah.
Okay.
Right. So can we move to? Should we do? How are we doing for time, Parag? Are we doing well?
We are all right. We have about 30 minutes, less than about 20 minutes to 25 minutes more.
Okay, may I ask one in this case?
Yes, let's last question on this case. Yes, go ahead.
Because of distorted distal femur anatomy, how to get the exact sizing of the femur with available size jigs?
So again, a great question. Fortunately, most of these extra-articular deformities are juxta-articular, which really means that the surface of your articular geometry is usually unchanged. So you do not need to change or diverge too much from your conventional measuring techniques. So whatever system you follow, you use your sizer in that plane and go exactly the way that you would do for a non-extra-articular deformed arthro technique.
Okay. So let's go to the next case, which is a very severe deformity. Yes.
So I'm sure this is bread and butter to everybody on the panel. Each one of us has addressed this, seen this. As you might imagine, this lady is rheumatoid, neglected, many intra-articular steroid injections. has been on DMARDs and so on and so forth, has been on a walker ambulation, very, very limited ambulation for this patient. So very quickly, in the next 5 minutes, Jacob, you want to take this, give us your thoughts around this?
I think I might just, all what I need probably is a wedge, and I'll definitely keep a constrained liner, a constrained varus valgus constrained implants on the table, but I think the MCL will be intact most likely in this. I probably need to build up the tibia, because if you take the lateral view, I can see the deepest part of the femur is still above the fibula. So if at all, I might need a wedge on the medial side. And then
the main question is about the MCL here, Jacob. So
I think the MCL will be intact most likely here, but I'll
Okay.
definitely keep a what do you call it, a varus valgus constrained implant there. I don't think I'll need a rotating hinge. I think the MCL will be intact. So the
Okay.
superior MCL is slightly more deeper than this.
Okay, so so this was actually a patient that we operated about 3 years ago, and she had massive global instability. You could pretty much swing that tibia anywhere you wanted. The MCL was in fact incompetent, as was the posterolateral corner, and she had massive bone loss on the tibial side. We tried what you just suggested, Jacob, which was we tried our luck with the LCCK type of a design, but we're still unhappy about the kind of stability that we were able to achieve on the table. So this was one of those cases where I actually went in with a hinge. Parag, can we go for the next slide? The post-op.
yes, it's on the screen. Can you see
Right.
it?
So,
Have you got it?
So we used a bone graft to build up the medial condyle of the tibia. We did not use a stem on the tibial side, but we used a LCC. We used a rotating hinge. Got a very, very good construct, good stable construct. This patient has, obviously being a severe rheumatoid, she has other joints involved, is basically a walker ambulator, walks within the house, has a walking target of roughly about 150 to 200 meters, more or less homebound, walks in the veranda outside the house. But this is just an example of having to use a very, very high level of constraint given the steroid injection. There was possibly some element of a neuropathic joint as well here. So possibly, we walked through that option, did not want to have a late failure. And consequently, we've ended up with a RHK over here. In fact, interestingly enough, Sachin's talk, we have 3 publications on RHK, and we have recently published 15-year RHK data in the Acta Orthopaedica, and we have a survival figure of 86% at 15 years. So it is really a robust treatment option, and it really stands the test of time. Right. Any other comments from any of the panelists?
So the bone graft, what you have done, what kind of a graft have you used to build up the medial bone defect? And
so this was part of the femoral condyle that we pulled out, the posterior condyle of the femur. We turned it around, fashioned the edges, and we used 2 screws, one going anteriorly and one posteriorly, cancellous screws with washers, right? And put morcellized graft between the surfaces. And this lady is about 6 months, I think, 6 or 8 months post-op. She's doing well. As I said, she's a limited ambulator, but is really stable and is able to do all the stuff that she wants.
Okay.
Okay, so I have a question, Dr. Rajgopal. Is that your choice of stem in these individuals who are grossly osteoporotic? Would you prefer to use fully cemented stems, stem extensions, or would you prefer to use hybrid stem extensions?
So if I'm using a long stem Sachin, I never ever do a fully cemented. I use the proximal third is cemented. The rest of it is basically almost like a press fit. More recently, in the last 12 to 14 months, I have gone off long stems almost exclusively. Unless we are using a very big wedge or a large graft, we use short stubby stems, fully cement them. We use bone plugs at the end, we fully cement a stem which is about 40 millimeters. And again, we look at recent literature data in Journal of Arthroplasty and Journal of Knee Surgery. There is excellent long-term survivorship of short stems in comparison to long stems. So mechanically, biomechanically, a short stubby stem fully cemented does very, very well. And today, I think almost all of my stems are short stubby, fully cemented with a bone plug on both sides.
Ashok, what about the femoral side? This particular one, the femur is a hybrid cementation, is it?
Yes, it's a hybrid cementation. We use cement in the proximal almost about half, and it is uncemented beyond that.
So your data on RHK is hybrid cementation. Can we take it like that? Your 15-year data?
Yes, it is. Yes, because this is my earlier work, and it is a hybrid cementation with 86% survivorship at 15 years.
Thanks. Yeah.
And it's the same implant, the same implant, same company implant. You didn't...
It's the same company implant, but the RHK has been modified in 2010, 2009, 2010. 2007 was a slightly earlier iteration of this implant. In fact, interestingly enough, 14% of my failures that we reported, out of that, almost 70% were the first iteration RHKs, where the locking pin and locking mechanism was not as robust. So we had femoral loosening, and in 2 patients, we had pull out of the cross screws that went into the tibial component. But ever since we've changed to the recent RHK, the rotating platform, our incidence of failures is actually only about 3%.
May I ask
one more thing, Ashok? Yeah, sorry, go on. Yeah.
Considering the chronicity of the symptoms and the quality of bone, would tibial sleeve or cone would have been a better option over the bone graft in this case?
So sleeve and cone is usually used for a cavitatory defect. This is a peripheral defect. If you can see, we have reasonably good cortex below. So, and this was really like an angular wedge. We could have used a wedge. Somehow I'm not a great believer in metal augments. And I think all over the world, people are actually going off metal augments and going on more towards biological or trabecular metal options. I reserve my trabecular metal devices for cavitatory central defects or where there is bone loss. And we again, are great sort of lovers of the trabecular metal cones. We have described, in fact, a stacked cone for periprosthetic fractures, and I'll show that in one of my revision patients as we just go along. So we use that typically, even in primary situations, only for central defects.
Right. Ashok, when you're talking about the cemented stems with bone plugs, we are doing it almost like the hips, where you use a cement gun and nicely put it in and do it like a hip. Yeah, right. Because that's exactly what I do as well. So yeah.
Can I just ask a question quickly?
Yeah.
It's regarding the the other RHK, the link RHK, which works very differently, where you have a metal going into the femur. Have you people used that? The link.
Oh, yeah, we have used it, but we usually don't call it RHK. The RHK usually we call it Zimmer, but the link we use a lot. Yeah.
What do you think about? It's a very similar, very different way of linking it. What is your comments regarding that?
It is not a both the RHK as well as the link, the hinge mechanism sits in the central, the post region. That's where it sits. In contrast to all other hinges, where it is the condyle which takes the hinge. So in a lot of ways, both are similar, I would think, the RHK and the link.
The peg is metal, inside poly, reverse of what these
Yeah,
are.
that is that. That's true.
That's very
But,
different.
in many ways, we find compared to, for example, the Depew hinge or any other hinge, this is these two are similar because they take less bone and the hinge mechanisms is in the intercondylar region.
The only challenge, Vijay, as we know, it's in the hyperextension situation, they don't work very well.
Yeah, more true of the link hinges. Yeah, correct. Yeah.
Yes, yeah.
Right. So we can move on to the revision situation. This is a 81-year-old lady infected 6 years after TKR. She had a two-stage procedure, two-stage. Can we go to the next slide? Can somebody quickly walk me through their protocols or algorithm for revision? What do you do? Very briefly, if you can cover that, somebody.
I think, sir, this case is shown some different and you're talking of different case.
Yeah, it looks different, yes.
Parag, sir,
I think
case number 5.
yeah, that's
this.
the one. That's the one.
Yes.
Yeah, no, this is the same. You can. This is the
Yeah,
this is
this
a lady
case.
who had a preoperative. Yeah. So this patient had she had infection. She had a two-stage. We did the first stage. This is her preoperative status at the time when she came to us with infection. So just walk me through their protocols.
If there are any discharging sinuses, send the cultures and all that, and see if we can find the organism before. I generally prefer to do two-stage, even though
Okay.
culture will give some indication. Yeah. Sorry, Ashok.
So in the interest of time, this lady was, she was aspirated. She went through cultures, CRP, SED rates, and so on. She grew Staph aureus. She had a stage 1. And how long would you wait after stage 1, and what would your indications be for proceeding to stage 2? So we knew the sensitivities. We put her on parenteral antibiotics. So
and an antibiotic-loaded spacer, I suppose. So
please go ahead.
Yeah, and an antibiotic-loaded spacer. And generally, the waiting time is anywhere between 4 to 6 weeks for me. If the SED rates and the CRP comes down and the sinuses all heal up and she's nutritionally looking better, then I would give a week of antibiotic-free time to see if it is if the ESR and CRPs don't go up, and if that's the case, I would go in. And especially if it is a known organism, I would be more confident to go in and do a second stage, anywhere between 4 to 6 weeks.
Yeah, we will do the same. We will not re-aspirate. So if the CRP has to be normal, the ESR must show a downward trend. It may not be normal yet. Clinically normal. Clinically, everything looks quiet. Then 2 weeks of antibiotics. If the CRP and the ESR stays the same or comes down, we're happy to proceed. If it goes up, then we'll have to reevaluate options.
Yeah, I think so. Just a query. I think that's pretty standard, Vijay. That's exactly what is recommended by anyone on the panel who subscribes to the one-stage revision. Anyone on the panel who believes that one stage is the way to go. A lot of talk about it. More and more people are turning in that direction. You have people like Feres Haddad, the endoclinic guys, Thorsten Gerke.
I think if you got a good bug, you got a good microbiome team.
And me both share a So static spacer or dynamic spacer?
We
I'm
always
happy
go for
with the static spacer.
Static spacers.
So everybody uses
spacer.
Yeah. Okay.
Yeah, static.
Does anybody in the panel? Does anyone on the panel remove the implant, autoclave it, and use it as a spacer?
No.
Sachin?
No, I won't. But I would definitely do an articulating spacer. I will not re-sterilize the implants for sure. So my preference would be to use an articular spacer unless there is compromised soft tissue envelope, which will then make me use a static spacer.
Right. Okay. And any comments about how many weeks of post-operatives after second stage would you keep these patients on antibiotics for any length of time, or do you just give them 3 doses and then done with it? 3 weeks, 3 months, 6 months, 1 year? What is the evidence?
Well, we send recultures at the time of second stage, just to make sure that we are not missing any pockets of infection. But normally our protocol is 3 weeks of IV and another 3 weeks of oral antibiotics in most cases.
Okay, Sharon, let me ask you an awkward question. Now you've done your second stage, you've taken your cultures, and the culture turns out to be positive. What would you do then?
No, then it will be a little more aggressive with our IV antibiotic therapy and hoping to keep it suppressed for longer length of time.
All right. Okay. All right.
I wouldn't be very worried about that. So if we do get the positive cultures sometimes, but there's no biofilm there because we removed everything. We have done a debridement second stage as well. So we'll take it like a one-stage revision. So we're not overtly worried about that, but we'll make sure we give more long-term antibiotics. Even if it is not positive, we'll give a minimum 3 months. Now the trend is to give more longer antibiotics. When we have positive, we probably give 4 to 6 months of antibiotics.
Right. Okay. So I think I've opened up a Pandora's box over there. A lot of options in opinion. All right, Parag, can you go to the next one where you can see? Yeah. So this is what we did for the question on the sleeve. As you can see here, we used a rotating hinge here. The only reason we used a rotating hinge here was the medial collateral ligament was completely chewed up. And this patient, I did not show you the intervening spacer x-rays in the interest of time. But what actually happened with this patient, again, this was one which we had inherited. The spacer had dislocated and this patient had been told to walk on it. There was attrition rupture of the medial collateral ligament. And so she was a very unstable inflected knee. So we had to do a second debridement and we had considerable bone loss and hence the need for the TM cone. We used a central TM cone with a constrained rotating hinge type of an option. Right. Shall we move on? Any other comments or?
So I think I'd like to ask a question. I mean, so one of the important things is, and there's a question that's coming up on my phone as well. So there's a question saying that what are the tips or technical tips from the panel for ensuring that you've restored the joint line correctly when we're doing a revision where you have obscured landmarks?
Okay, so is that for me, Sachin, or?
No, it's to the panel. I think you start off by answering it, and if the other panelists have some extra tips or tricks, then they can definitely share it there.
Okay, so there are three anatomical landmarks, Sachin. The first is the medial epicondyle. It is rare to have destruction of both the epicondyles. So usually one or both of the epicondyles will usually remain intact. So that's your index. You want to place your joint line about 2.5 to 2.6 centimeters distal to the transepicondylar line. The second landmark is the position of your patella in relation to your femoral component. You want to seat that in the middle of the trochlear groove. The third indicator of your joint line level is the head of the fibula. And that is almost always intact. So about 1.5 centimeters proximal to the tip of the head of the fibula, 2.5 to 2.6 centimeters distal to the transepicondylar axis, and with your patella seated in the trochlear notch of your femoral component. Those are the three things that I would look at.
Perfect, perfect.
You can also do a mid-flexion instability test like in this thing. We're not using a hinge, of course, yeah. We're not using a hinge. then you can look for instability in the middle range. And that again will tell you that you have elevated the joint line.
Okay, fine.
Right. Okay, so let's go to the next patient. This is a 71-year-old patient, left TKR 2010. He had no comorbidity. He had a history of fall a year ago. This was referred to me about, I think, 6 or 8 months ago. And can we see the post-op, the pre-op X-rays? Right. So this was the patient, and he was obviously in pain, but was told to continue with his ambulation. And believe it or not, he walked on this with a walker for about 2-3 weeks before the pain became excruciating. And so, Parag, maybe you can take the case and tell me.
Yeah. So the first thing what I would do in this case is to rule out infection. So do all the studies for infection, aspiration, and ESR, CRP. Assuming there is no infection, then because it's 1 year since the patient had the fracture, and you said walking for 1 year. So was there an infection? Did you?
Yes. So we did the entire algorithm for the infection. We did all of that.
Right.
In fact, we even did the synovusure for this patient, and that was negative. His cultures were negative. His serum and his synovial fluid CRP was clear.
Right.
So we excluded everything from.
So if the infection is ruled out, then for me, then this would be a case where you can already see a lot of bone loss. I would think of a hinged prosthesis for this case, and think of various options to build up the bone loss, so I don't end up with shortening. I particularly like the link hinge prosthesis, and
Right.
I've been using the link hinge process for a while, and you can get those augments which we can put and then build up the height. It's relatively easier to an RHK. I've used an RHK also, but I find it easier. And my particular choice in this will be a hinge prosthesis and link kind of a hinge prosthesis.
Sure. Great. Any other comments from any of the other panelists?
Looking at
the extensive. Sorry, Vijay, go on.
Yeah. Go ahead.
For the best part of this is the extensor mechanism seems to be intact with the tibial tubercle area seems to be okay. I would definitely keep the hinge as a backup. I wouldn't jump to that straight away. Maybe the MCL on the tibial side may be suspect. I would go and remove everything, and here the joint line has to be built up nicely, and I definitely will need augments, and I would definitely look at a sleeve. Metaphyseal sleeve is something which I'm very familiar with. I would look at that on the tibial side and see if I can build it up and bring the joint line to normalcy, provided the MCL is intact and I'm able to get that ligaments in place. If it is not, then straight away go for a hinge here.
Yes, so I was assuming that the MCL would not be there, especially on the tibial side. The MCL is not there.
Here,
that's a point.
it looks. Can I come in, please?
Yes.
It looks pretty dicey because there is nothing on the metaphyseal side. It's almost like you would be doing a proximal tibial replacement in a case like this. I doubt whether we have.
I'm not so sure.
I doubt whether you will have much, because you are right away going to the end of metaphyseal area once you take out the implant on the tibial side.
And not only that, if you look at the head of the fibula, and 1 centimeter above would be the joint.
I think I would keep that also in hand.
So I would keep certainly a tumor prosthesis.
Yes, I would keep a tumor prosthesis in hand.
All right. Okay, so different opinions, all right, all correct. So I'll tell you what we did. Can we go to the next slide? Yeah, so Parag, you're absolutely bang on. The tibial insertion of the MCL was compromised. There was a comminuted fracture of the lateral tibial plateau. So effectively what we did was a rotating hinge. This was completely sort of smashed up. It was very, very unstable. And one of the things that we use a lot of are these, when we do use long stems in difficult revisions, we do use a offset stem. And I don't know how many in the panel use it, but we are great lovers and advocates of the stem. For one thing, you can actually posteriorize your femoral component using the same size. You don't necessarily need to upsize it by using the offset in the opposite direction. You can actually reduce the flexion space very, very effectively. In this case, of course, because of the constraint of everything having been lost, we used a rotating hinge, and we have got a reasonably good construct. We have restored the patella back to the trochlear notch, as you can see on the lateral view. And this patient has really done quite well.
May I ask one?
Yes, so 1 or 2 questions before we go to the
Sir,
last case.
You have built up the bone with cement. How long will it last? And I was about to comment about that fibular head, but already marked.
Yeah. So, see, I think at the end of the day, your alignment of your joint line levels in these very difficult situations, if you're able to bring the patella back up to the trochlear groove, I think you've done reasonably well. Okay. These are difficult situations, not absolutely ideal. So the answer to the question is, since we have restored our patella in alignment with the trochlear notch.
Ashok, these days you do a cemented tibia, yeah, for this one? The stem.
Joint line. So I was just coming to that, Vijay. This would be one of the few indications where we have extensive bone loss. We also had, unfortunately, I hate to sort of admit this on a public platform. It's really not the right thing to be saying, but in an ideal situation, I would have used a couple of TM cones. Costs were a constraint, so we did not have option. We use cement. And to answer your question on how long it will last, I think this knee will last for at least 15 years, only because this is a fully cemented stem. And again, it is a press fit stem. We have got a good column of cement all the way distal, so I don't see this subsiding.
Can I just ask a question, Ashok?
Yeah.
Jacob.
One of the issues I have this, one or two companies, the housing for the stem in smaller femurs end up eating the anterior cortex, particularly with a couple of companies. And so when I have a smaller femur, that's why I started slowly going towards link in some of these. Is that a problem, or you get it with some other?
No, I think that's a great point, Jacob. I couldn't agree more with you. So that is one of the reasons why I went off from the straight stems onto these offset stems. And by using offset stems, you can actually manipulate your femoral component and the stem housing to accommodate in the widest part of the medullary canal. All right.
If you sorry, just to make one point, if you didn't have the cost constraints with the metaphyseal sleeves, you're able to raise the joint line quite nicely and use it in situations like this. Even if you're
yes, absolutely.
Yeah.
Sharon, the only point on the joint line, even if I had to use a TM cone, I would not change too much on this, because as I said, I'm repeatedly saying,
patella is
cool. I would not like to sort of elevate it more and get a patella bar. That's a bad news. Yeah. Okay,
so let's go to the last case. About 6-7 minutes more for the last case.
Yeah, well. So.
See the X-ray.
Right. So we'll go straight to the. This is a TKR done 6 months ago. One of my patients fell at home, hypertensive, and we can get the X-rays. And this is really what she had. So this is a closed fracture, hemodynamically stable. There's literally pulverized bone, elderly patient, osteoporotic, osteopenic. Any takers for any takers?
I think the choice is pretty much straightforward. Tumor prosthesis here, I think.
Yes.
Okay, tumor prosthesis.
Anyone? Also think of a tumor prosthesis. Because the moment you try to remove the femur, the whole bone will go, and you will not be left with much, because
I have a trick in these. In case, I'll always have a tumor process there, but I'll put a nail from the distal femur that aligns it. That aligns it, and then I use a nail plate device. I don't know, we have written it up. So we use the nail to center it, so it reduces without me opening anything. I don't touch any of the soft tissues or the bone. Just through the intra-articular region, we put a nail in, so it aligns it, and then we put a plate. But of course, if there's no bone for the plate and the nail to hold, of course you'll have a tumor process. But I find that
so great points, all of them. Tumor prosthesis, nail. So
you don't need to jump to a tumor. You have these plastic augments with a link. I would use that and you can get away with it. Yeah.
Right. So that's another option. So we have. If you can go to the post-op picture, Parag, thanks. So in this, we've actually used a TM augment. We have used a long stem. We have used a rotating hinge, and in comminuted fractures, we have actually at times used up to 3 TM augments stacked like a Sikh kebab. We thread the augments using a long 220-240 stem, and we take the comminuted bone around it, and we have actually, again, our article has just been accepted for publication on the role of stacked TM cones. It is remarkable, at almost 12 to 14 months, the entire lower end of the femur is completely reconstituted by trabecular bone. It is an excellent augmentation device. It stimulates osteogenesis, and these patients are functional. They walk very well. So this is really what we did in this patient. Of course, we used 1 TM cone. We've wrapped the comminuted bits of bone around it. This lady is now, I think, about 7 or 8 weeks, very recently done. I think we did her sometime in the end of February, so we still don't have long-term data on it. But at our last follow-up, which was about 4 weeks ago, her stitches are out, wound is healed well, and she's doing reasonably well. So hopefully, maybe at some future point in time, we'll give you the follow-up x-rays of this patient. But we have now almost about 23 patients of severely comminuted lower end femurs where we've used up to 3 cones with excellent reconstruction of the distal bone.
So did you use allografts, or how do you
No, so we used the same comminuted bone. We just, when we removed the femoral component, obviously everything just came off. There was just a mush of bone. We just wrapped that around the femoral around the trabecular metal cone, and we thread the femoral implant through the cones, get a good proximal metaphyseal fix. Sometimes we will use 280 stems, go up to the isthmus at times, and it gives us excellent fixation. And we allow weight bearing typically at between 8 to 12 weeks. That stimulates osteogenesis, and we haven't had a single failure yet. Our longest follow-up on this is now about 7 years. We have published this initially in the Journal of Knee Surgery, and then again in the seminars in arthroplasty. So we are really, really sort of great believers in this
how do you explain, how do you explain that the load in the metaphyseal area is in the initial period relying only on the cement on your comminuted bone pieces and the stem which is holding it? So the loads are pretty high. So, how do you prevent early failure? What are your tips and tricks in this?
So we keep them strictly non-weight bearing, Parag. If you look at literature data and lab data on trabecular metal cones, there is enough fibrosis at between 3 to 4 weeks, which is a stable fibrosis. It stimulates fibroblasts and osteoblasts. And in a matter of about 3 months, there is enough cancellous bone reconstitution around the TM cones. We've actually had one patient who had an osteoblastoma, or what was biopsy proven to be osteoblastoma. And unfortunately for this patient, at about 7 months, he came back with a recurrence, and when we biopsied it, it turned out to be an osteogenic sarcoma. So we actually had to go back in and remove the TM and everything. And at 7 months, this TM was completely covered with reconstructed and reconstituted bone, to the point that that osteogenic sarcoma had actually even infiltrated into this. So at 7 months, there was excellent reconstruction. You need to protect these joints in terms of articulation for a period of at least about 4 to 6 months. So in principle, it works very well. These are very, very difficult and challenging situations. But the taste, the acid test is in the taste of the pudding. As I said, we have 6-year data on this philosophy. We would like to wait for another couple of years and publish our long-term data at about 8 years. But so far, we have not had a single failure.
How easy was it to remove the TM process? I mean, that's something scared. I get scared with this. How do you remove it? Is it easy or?
You can cut through it, Jacob. You can cut through it. The only thing is there's a lot of fragments that go all over the place. Make sure it doesn't hit your eye or your assistant's eye. You cover it with a wet swab gauze. They're easy to cut. They are very malleable. So I'm getting a message, carry home message. So I will go back to where we started off with what Sachin did so elegantly. Constraint is a great option. We need stability. Stability comes through constraint. The philosophy is use the minimum constraint that will give you the maximum stability. That can be in reusing a CR knee, a PS knee, a dish, mid-level constraint, a rotating hinge TC3, or various forms of hinges. So on that note, I'd like to thank Parag, Sachin, and the ski team. Thank you very much. It's been a real pleasure. Look forward to further interactions.